So I'm presenting on behalf of the individuals that are listed in the abstract, all of whom have been involved in the development of thinking about and trying to come to terms with hepatitis C elimination as a province of a moderate size in Nova Scotia. I've changed this presentation a little bit from the core that was put together as an abstract, mainly because it seems clearer to me than a year ago that people have a concept of elimination. And apparently, according to some of the speakers earlier today, even Dr. Sherman was saying, you know, we think of this as an infectious disease that's eliminatable. And I thought, whoa, a year ago we weren't here, so this is pretty incredible. So I've changed this a little bit to going from talking about the exact implementation, which has been coming along, to really highlighting some of the challenges in the system we have within a public payer system in Canada that are really problematic to going forward with implementing any sort of strategy like this. Bits and things. Okay, so I can skip over all this. Everyone knows this is an infection and infectious diseases can be eliminated. We've done it before, we've done it with bacteria, and we've done it with viruses. And we've done it not so much without a vaccine before, but we do know that hepatitis C is something that we can probably eliminate. Do we know it for sure? No. Anyone in the audience who doesn't think hepatitis C can be eliminated? Ah, excellent. Okay, good. So I think can and will be are two different things. But we know that with highly effective therapies, at least we've got a shot. And of course, there's people in this room that are working on vaccine, which would be a very, very useful adjunct to any elimination or eradication strategy. So what do we know about hepatitis C in Nova Scotia? Well, we don't know a boatload, honestly, and a lot of this data is courtesy of the GI folks who treat more people in Nova Scotia than infectious disease does, and they've actually had a longitudinal database. They have about 1,100 Nova Scotians within their GI database. It's unclear how many people are infected. There's all kinds of numbers that get tossed about, and government makes me say numbers, and I have no idea what the numbers are. And approximately 30% of the individuals in their database actually have advanced liver disease. So when you look around and take data that was taken from our provincial lab, all of our testing is done centrally. So we have some aspect of what it may be happening with hepatitis C, but you'll notice I haven't put numbers up here. I generally deal in numbers. I'm more of a basic science person than a qualitative person, but I didn't put numbers in here because I think these are so unreliable that it's not useful, but this is proportionally the case of what happens. That's Nova Scotia in the background. Cape Breton's in the upper right corner, that island-like bit with the green dot. And what we've seen, particularly over the last months, is that there have been a lot of new cases in Cape Breton, and it's becoming a focus where we know that we have a lot of new hepatitis C. Do we know the exact numbers? No, and I think we grossly underestimate them. But numbers-wise, central, where we have most of our providers, our provider base in Nova Scotia actually reflects proportionally these different size dots, and these are proportional to absolute numbers. So this was between 2014 and 2016, and we have a lot of hepatitis C like everywhere else, not out of keeping with some of the areas. And I was talking with some women from the Yukon this morning who are doing some great work up there, not quite proportionally the same amount, but we also don't do a great job of screening. So how does hepatitis C care work in Nova Scotia today? Much like what happens in much of the other parts of Canada, we have random people who get randomly screened, not part of a consistent and coordinated program. Testing results go back to whoever may have ordered it. If it happened to be somebody who has a physician to follow up on them, that's great. If it doesn't, the result kind of just sits. If it's a new result, it goes to public health and they contact the person as a notifiable disease. Then there has to be a referral to a physician who can actually provide care and treatment, and there is variable uptake as to how that happens, where it happens, and when it happens. And then from there, there's access to therapy. We have the usual restrictions on access to DAAs in the public payer system based on the level of fibrosis to date. So there's a lack of coordination, there's a lack of engagement and care, and we don't know a whole lot from the screening perspective, along with having the same challenges to actually getting access to therapy in a public payer system. So I don't know, that doesn't sound suboptimal to me, or doesn't sound optimal to me, and so we decided that we wanted to go forward and think about a plan that may be a little different. So what happened in Nova Scotia several years ago, well, 24 months ago, is that we moved from multiple health authorities to one health authority. And in my head, being wide-eyed and naive, I guess, I thought this was a great opportunity, and I still do to a certain extent. You go from having multiple health authorities who have multiple regulatory groups to one place where you get all of your hepatitis C work could be done in one central area, and everybody would talk to each other, and we'd all be happy, and we'd have brunch and sing Kumbaya, and it would be great. So I still think that could happen, but there are three things that I think are very important to point out here about how things work in Nova Scotia at a health systems level that are really challenging to bringing forward anything else that we do in going forward. And I think they're probably the same in most other provinces, although I can't say that for sure. Number one, all clinical programs that we deliver, so if we're going to deliver a program for hepatitis C elimination, that gets delivered by the health authority. Now, the health authority is not the Department of Health and Wellness. So I think it's really important to kind of understand that, because the Department of Health and Wellness is actually where public health resides. And it's also where money comes into that's given out with the budget each year. So I sound a bit like I'm not talking about Hep C, but this is really important. All funding for clinical programs outside the drug cost in Nova Scotia are disseminated to the health authority. And then the Department of Health goes, excellent, we're done. We've given you money, figure out how you're going to spend it. So you can see where I'm headed here, right? There's a disconnect. And it's important for how things are going to get rolled out, I think. So care programs that require a therapeutic agent, like a drug, may or may not be involved in the decisions around drug availability that happen through Pharmacare. So those are three separate points, and there's not a lot of linkage between those three separate bits. So if you want to deliver a program that involves drug as your main mechanism of elimination or cure, but you don't talk to the people who are actually making decisions on how and when the drug is available, it becomes a little bit challenging. So I think great opportunity and some challenges in how the system still works as to how one would go forward with hepatitis C elimination. So Hep C, we have great engagement with public health. They were very on board from the very beginning in 2014 with coming to us and helping us to identify people who were newly positive. Not changing the screening or identification system, because we're waiting for national guidelines on that, but just allowing some conversation about how we might interact more closely with the hepatitis C program. We have a lot of expert providers who are all engaged and willing to contribute. And we have a group of individuals, both as providers and as people in the community, who are all very invested. So this was the model for elimination, and it involved a stream. Basically, this is not rocket science, and it's not original. This is not the point here. It's just that we're trying to do it, I think. And the idea is that you identify people, you have an automatic referral to a provincial program, there's centralized triage and workup, referral to the right provider automatically with an algorithmic approach to treatment timing and treatment choices with education and evaluation. Oh, I did something really bad. Oh. I fixed it. Hey, I wish Nova Scotia was like that. Look, it's fixed. And this is all in the context of, can I get a button like that to take home? This is all in the context of harm reduction and correctional system. So our harm reduction bits that have been ramped up in the last year in Nova Scotia all go through public health as well as primary care. So that linkage is already in place and part of the discussion around hepatitis C, the correctional system we're struggling with. And that brings us to the health research part that will be embedded in this through both treatment support, evaluation, and education, both health systems providers and patient outcomes through a registry, and that's an implementation science part that the Maritime Patient Support Unit is going to be providing. So we think it requires these things, again, not rocket science, engage people, innovative partnerships, and a commitment to assessing what we do in research. And that doesn't mean waiting till you have the perfect harm reduction system to embed in this. And it doesn't mean waiting until you have the perfect program, but continuing to commit to evaluating as you go, and also to doing research. So for the identification, I told you we haven't changed that, but when a new person is identified as hepatitis C positive through public health, we are also notified as the provincial program that we've just started rolling that out. There's an automatic referral or notification to the provincial program, and then we actually go through and contact the person. We start the automatic process of triaging the person, working them up for other liver disease, and they automatically, once that part is done, get a referral to an infectious disease or GI specialist. So, where are we with all that? We are at the automatic reporting part from public health has just started to be implemented on a beta basis, just to ID for the moment, as well as admin support and nursing with a nursing review at the end. So basically we've downloaded a lot of the administrative parts to admins and not made the nurses do this. So we're going to go through. I'm going to tell you this is since 2014. These are the groups that we've put in. This is the meetings that have been had. You're going to miss Justice and you're going to miss Pharmacare because although approached, we've had some difficulty in bringing them in. Critical nodes, you need to know who's infected and we don't yet. We haven't been able to get the interdepartmental governmental parts perfectly in line, but it's coming along. And since I have a red card, I've never been red carded. That means something in soccer, right? So I think I'm going to leave you with this, though, because I think this is really important as we go forward. It's not only just drug access, which we started to address with the last point there that I whipped through because I was too long was that we've got this national strategy, and people have asked me, do you think provincial strategies are more important than national? No. I think we've got to have a national strategy, but everything gets rolled out at the provincial level. So not acknowledging a provincial plan is not helpful either. So that's number one. Number two, it's not that they didn't want to come to talk about this from Pharmacare. I think they were asked multiple times, but there's been this parallel process going on from a pricing perspective, which is great, right? We've been able to achieve this great thing, I think, that got announced recently with the PCPA, which is fantastic. I don't know what it is. I haven't heard the details. I don't think anyone else has, but while people were involved in that, many of the individuals in at least several of the provinces where I've talked to physicians or providers or people involved in this process of trying to develop programs provincially, they've had some trouble getting people motivated to go forward while this process was going on. It was kind of we shouldn't talk about this till we get this stuff straightened out. And so I would argue that that's completely not the right way to do this. It's to talk to each other as we go along, and perhaps maybe have included formally some consultation at the PCPA level with medical experts or other experts who might have some input on the process.
Thank you. I guess it's lunch.